little bit about the new valve technology that we are going to see in the next 5-10 years with all the problematics and the adventures. You know, the world is changing quickly, and we can see it today. 2 years ago, no one knew about ChatGPT, and now this is ruling our life. And if you want to predict the future, no one can. Yogi Berra, a football player, said it's tough to make predictions, especially about the future. Just take the phone, how it looks when we were children, and we thought that the big development is this one, but apparently year after year we are amazed to see new things are coming until the smartphone. And if you want to predict what's going to be in the future, really no one knows. Maybe this is going to be the phone in 5-10 years on your hand. So when you come to valves, it's also very difficult to predict the future. But let's try and see what's forthcoming. First of all, we have to give a salute to Alain Cribier. It's about 23 years since the first TAVI was done in April. Alain Cribier died last year, and he was really the one that started the whole revolution, I would say, of TAVI. We can see that age is a very important determinant of aortic stenosis, and as the population is aging, we see more and more patients with aortic stenosis, and it's expected that in 2040, 15 years from now, we'll have 50 million people that will need the TAVI. With mitral, it's even more complex. Age is also a very strong determinant, and we can see that in 2040, the numbers of people that will need some treatment for mitral regurgitation will be huge. If you take the global interventional structural procedure at 226, it will be next year, it will be close to 500,000. So definitely structural heart disease, TAVI and mitral disease is going to be a very important part of our life in the upcoming years. I'm going to talk quickly about 9 quick topics: the completion of TAVI, mitral, and TVR programs, the improvement in imaging, the generation of the valve and valve-in-valve, tissue-engineered valve, and 3D printed valve, and polymeric valve, which is really going to come and are on the verge. We will talk a little bit about simulation and robotic, and definitely what's coming is the AI revolution. So I believe that Evolute low risk and partner 3 trial really opened the gate, because they have shown that we have a significant decrease in events, morbidity, mortality compared to surgery. And this was the first big trial that told us that TAVI is really going to win. And Braunwald in 2019 said, this is an historic moment and all of us here should remember it. So we are 5 years of this beginning of this revolution. When we talk about aortic, there are a lot of new things coming with regard to, let's say, aortic stenosis with concomitant disease, coronary, mitral, tricuspid, asymptomatic aortic stenosis. We get more and more studies coming in, moderate aortic stenosis with heart failure, and severe aortic regurgitation, and we had a wonderful lecture from George regarding that. So definitely the field of aortic valve disease is going to change. Now, still from the slides of Marty Leon, a lot of questions, and we have a lot of studies that are ongoing, and we have the answers in the next upcoming years. The bioprosthetic durability, life thickening, cerebral protection, yes, no, yes, no. We have different clinical outcomes. TAV and TAV, which is really becoming a major issue, and we're going to see a huge number coming in the next few years with the issue of coronary access. The question of echo-derived gradients, what this has to do with hemodynamics. Pacemaker, paravalvular leak, post-TAVI disturbances. Do we need so many pacemakers? From 10 to 20% of patients, antithrombotic therapy, etc., etc. So there is a lot to do with aortic, but with mitral, the situation is even worse. Mitral valve disease is a big mess where aortic stenosis is usually one etiology. With mitral valve, we have the prolapse issue, we have the rupture of the chordae, we have the annular dilatation, and apparently each one of them needs a different solution. And as you can see, we have many, many devices all the way from leaflet repair, the mitral clip and Pascal that are currently the winners. But we have many devices for mitral valve replacement. Some of them were already approved. But we have already direct annuloplasty, indirect annuloplasty, ventriculoplasty, etc., etc. As I mentioned, edge-to-edge is currently the winner, but we do know that we're still living sometime significant mitral regurgitation, and the question, like it was in the Amphitheatre procedure, what's going to be, and can we take it to younger patients? So I think that replacement will also have a role. Will it be in high-risk surgical, MAC, although we see more and more patients with MAC being done with TEER, recurrent after surgical repair, alternative to surgical repair, etc. Tricuspid is a very big growing field now. We called it for many years the forgotten valve, and in the last 2 or 3 years, you can see huge numbers of papers coming regarding the tricuspid. Suddenly, it became a big thing. But we still have a lot of questions. What's the best imaging, echo, TE, ICE, etc., etc.? What are the parameters? How reversible or irreversible is the right ventricular? What's the time of intervention? What's the safety of the procedure? What role do we have with the pacemaker? So a lot of studies and a lot of data will come in the next few years regarding this. Because we have so many questions, we have so many our answers, and we have a lot of new technology, all the way from annuloplasty, direct, indirect, and probably you heard some of them. A lot of them are running in clinical studies, and we'll have to wait and see which one of them is winning. We have the leaflet devices, which were apparently successful with mitral, and we have it with the tricuspid, the TriClip studies, the Pascal, the Maestral, etc., etc. Some of them were there and disappeared like the former. We have a lot of success with some other idea like the heterotropic valve in the IVC and SVC, the Tricentro. But what seems to be is the entire orthotropic valve replacement, and we had the Evoke by Edwards already approved by the FDA, and some of them are on the way, like Trizol from Israel, that you can see that are running advanced clinical studies. What seems to be a nice way to tricuspid replacement, and in 20 minutes you can do the replacement with very high success. On the other hand, we'll have a lot of improvement in the imaging. You can see also that virtual reality and AI are taking place. It's much easier and much less complication today to puncture and to know exactly where you are. And what's going to dominate our future is what we are going to call fusion imaging as well as artificial intelligence. So you can see the angiogram, you can see exactly the planes, you can see it in the short axis and the long axis in TE, and you can know exactly where the implantation, where the coronary is, etc. So definitely imaging is going to change the way we'll practice. As I mentioned, valve degeneration is very important. You can see surgical implants and explants from patients that had valves 7-10 years ago. With the numbers of TAVI that we are doing today, we know that we'll have probably a lot of patients coming back, like a tsunami of TAV and TAV, or valve in valve. The reasons we know today a little bit more about the bioprosthetic degeneration. Its intrinsic mechanism like immunological reaction, inflammation, thrombosis, and pannus, those are intrinsic. But we have also extrinsic mechanism like graft fatigue, hole formation, tearing, and abrasion. There are several companies working on that, like De Facta from Italy, that are trying to have solution that will cover the valve, and we can see early results of a study showing commercial valve after 6 valve explantation, and those treated with those special solution that are protecting the leaflets from degeneration. But nevertheless, the numbers of valvular valve is growing, and you can see what's the problematic of putting a new valve in an old valve, mostly with the coronary artery, and you can see, and we have today a lot of solution. The splitter has already got FDA approval. We started from the Balanika, but today we have several companies dealing with that. But the future is not in that. The future will be tissue engineering valve. And there are several methods to this problem. We know exactly today what is the functional structure, both on the macroscopic and the microscopic level. And if you look at that, it's a very, very complex organ. You know, the ascending aorta, the sinotubular junction, the sinuses, the cups themselves, the annular, each one of them is a totally, totally different kind of tissue, different collagen, different things, the way it works in diastole and systole. And we are learning today exactly what should be the structure. And there are a lot of work for regeneration of valves, taking all the way of decalcified scaffold, putting cells, drugs, and trying to bring a degenerated valve. It has a lot of problems all the way from the immunological reaction, alignment of cell, the adhesion, electrical impulse, oxygen supply, and mechanical synchronization. So despite the fact that it looks the more logical thing, the way is much longer, and I think it will take a decade or more to take this year. But what we see more is other technologies like the printed valve, and there are already some reports about 3D bioprinting of valves. Again, it's not an easy way because it takes a lot of steps, all the way from the model, the biomaterial, the ink, the bioprinting, all the way that conditioning to bring it to the patient. And as you can see, there are 4 big steps. You have to take multimodality images, CT, MRI, echo, 3D, do the processing, the segmentation. With a computer, we can do the entire design and modeling, and then do the 3D printing. The nice thing here that you can adjust it to the patient. So it will be the future of precision medicine, where you can design the exact valve that your patient will need. Again, there is a lot of work in it, and I believe that we'll see some good results in the upcoming years. What seems to be more logic even is the polymeric valve. What is the advantages of the polymeric valve? First of all, it's the biocompatibility. There is reduced risk of blood clots and rejection compared to the other material. The hemodynamics allows design flexibilities and optimal blood flow. The durability is a major issue. Today, we don't want to do TAVI in patient less than 70 or whatever because we don't want them to come back. But apparently, it looks like with the polymeric valve, will have longer lifespans of the bioprosthetic valve. The manufacturing will be easier with scalability and more cost effective, which is currently a big issue with the valve, even though the price is less today than it was 10 years ago, it's still very expensive. And lastly, it will reduce calcification with the new polymers. And you can see that we have a lot of work today with polymeric valve. There is a review showing that polyurethanes with different carbohydrates solutions, you can do different valves. And just last week or 2 weeks ago, on June 5, we had approval and the first commercial approval in India for this valve. It's a company from, I think, Utah, Foldax, and we're going to have first few implantation in India of this polymeric valve, and we'll have to see whether it's a winner. Another issue which will come and growing is simulations and robotics. You know, despite the huge developments with AI and other things, we're still teaching in the old way. We still have our congresses with the live cases like they used to have 100 years ago. But I believe that with the improved imaging today, with the new cath lab, simulation will become a very important part of our life. There are several simulation companies today in the world that can show you exactly what to do, how to do. You can train, you can see the patient, the valve, etc., and you can get a lot of experience with simulation. And lastly is the AI revolution. It's amazing to see how AI is taking our life so quickly. And in 1 or 2 years, AI is engaged in preoperative planning, helps us in imaging analysis, predicting the procedural process and the risk. And you can say today, if I put my valve here, this will be the kind of obstruction or problem or how to place it. It gives you a computation modeling that you can do a patient-specific valve. And as I said, we'll have a precision medicine. It will help us with imaging and robotic guidance, and definitely help us in the future with post-operative monitoring and detecting early signs of deterioration. So AI is really going to change our life. And you know, just looking at papers with AI, I mean, the numbers is growing on a daily basis. Every hour you have new papers. This is just one of them to show you that ECG screening can detect very nicely aortic stenosis without echo, without anything. In ECGs that we couldn't say before that there is a problem. So I think that in 5–10 years, an eye and robotics will change the way we manage the patient. I think that the organizers of this course in 2 or 3 years will have to start with AI and finish with AI. And it will bring us to the question, basically, who is taking control? Is it still us, the operators, or would it be the robot? Or maybe we'll have to find some way that we will work together. So I would like to finalize and say where we are. We are here in the middle. It's a revolution. We don't believe and feel, but apparently there is a big revolution in the midst, and we are actually now in the middle of this revolution. And only maybe in 5–10 years, when we approach here, we'll understand exactly what happened. So with this, I'd like to thank you very much and invite all of you to our ICI meeting in December. First week of December, we'll celebrate 30 years of ICI, and hopefully we'll be able to show a lot of the new advances in TAVI and structural disease. Thank you very much.
All right, this was Chaim. This was an amazing talk, and you know, and again, very much appreciated, particularly in this difficult times for the wider geographical area. And wish you the best, and congratulations for all the achievements and the very much forward-looking things that you're going to explain further live in ICI in December, and again live here next June. Thanks so much, so long for this transition to everybody. And we move on to the next special session. We're going to have Dr. Iakovou, Dr. Fremidis, making new therapies more accessible to patients.